Good morning.
Morning, Pam.
Morning, Pam.
I'm gonna let everybody else in. Right now, it's only the four of us, so there's a few more coming.
Okay.
Morning.
Good morning. Dr. Murphy, I sent you an email the other day or a text message.
I know. I have to get back. I'm so sorry. This vaccination thing is just taking me down. Oh, we've already vaccinated almost 2,000 people.
Nice. All right. Yeah, I just wanted to bring you up to speed. Doesn't have to be now. It can be after the meeting if you want.
Yeah, let's do that.
Okay.
Good morning, everybody.
Morning, David.
So,
What's up?
Hey, Pam, I have all the notifications when they have to be read in.
Okay, great.
And
I will turn it over to you at that point.
Okay, and the BLS adjuncts.
Okay. Did do we have an official did you guys send out an official oops, I'm not talking. Oh yeah, I'm okay. Did you send out an official agenda?
Yes.
I only see the minutes.
Nope, there is an agenda associated with it.
Got it. Thank you. This is an old agenda though, Bill.
January 4th, 2021.
The one attached to the thing she just sent out says November 2nd.
It should be the minutes from November 2nd.
Yeah, but if you look, pull up the form, the agenda says November 2nd, and that's the old agenda. That's okay. I pretty much know kind of what we want to go through, so.
All right, I'll get a new one to you.
I like the way Kelly Kohler's looking now.
I figure it's better than me wearing a mask, Pam.
Yeah, if I shut my door and lock it, then I can take my mask off. God, everybody just walks in my office like perpetually.
Wait, that's an option to shut and lock your door?
For now, anyways. So we have, let's see, myself, Arshad, Jeff, Evan. So we're one, and Dennis 1, 2, 3, 4, 5, 6. So, oh yeah, we're good to go. So, good morning, everybody. It's 9:31. So why don't we get started? What we'll do is Karen on here?
No, she's not.
Okay, Bill, do you want to do a roll call then, just so we can have the exact attendance? Because
Sure.
some people sign up with phone numbers, so I don't know who they are.
Okay. Dr. Murphy,
Yes, present.
Dr. Papish, Dr. Ashard.
He's there. Just give him time. Yeah, he's waving
Okay,
his hand to you.
I see that. Dr. Larson. Dr. Stu Miller. Dr. Burtis.
Hey, Bill, real quick, for folks that are on their phone, if you are muted, to unmute, I believe it's *6 to unmute yourselves.
Okay. Dr. De Crossard or Dr. McGinley. Dr. Wasserman, Dr. Mao.
Hi, Dennis here. Happy New Year.
Hey, happy New Year. Thank you. Dr. Chung, Dr. Natovis. Dr. Midori or Dr. Stoppel. Dr. Templeton or Dr. Sabia. Dr. Raybridge or Dr. Greenhut.
Here. Greenhut is here. Good morning.
Okay, good morning.
Morning.
Dr. Mead, Dr. Rowntree. Dr. G. Thomas.
I'm here.
Dr. DeBrutus, Dr. Papish, Dr. Ibrook, Dr. Cohen.
Yep, good morning.
Good morning. Dr. Santos, Dr. Kakuza, Dr. Larson, Dr. Quintero. Okay, so that's 1, 2, 3, 4, 5, 6. We need 8. Do we have any other physicians on board that I did not call?
Well, what we'll do is we'll start the meeting because I'm sure 2 more people will sign on.
Yeah, I'm just letting a few more in from the waiting room there.
Okay.
It kind of built up while I was there, so we might have a few more.
Open that waiting room. Open that waiting room.
Dr. Midori is there.
Papish.
Okay.
Hey.
Okay, Mark, thank you.
And Eric Larson's on too.
Eric. I thought I saw Dr. Midori come in also.
Yes, she said.
Okay.
Good morning, Bill. David, Pam.
Good morning. If anybody didn't hear Bill call your name, please just announce yourself to him so he can put you on the attendance.
Stu Miller.
Okay.
There's David.
Gigi Medor.
Yeah, we got you, Gigi.
Oh, perfect.
We saw you sneak in. So we have a quorum now, Bill.
2, 6, 9, 10. Yes.
Well, thank you, everybody, for joining on this snowy morning. I bet this is the best way for us to get to each other and be able to have a meeting. So Karen had sent out the minutes from the November 2nd meeting. I hope everybody had a chance to look at them. They weren't long, so it was easier to go through. At this time, if anybody has any corrections, additions, deletions, anything they want to add to it, please, let me know. Otherwise, if there's no problems with the minutes, could I ask for a motion to accept the minutes?
Motion to approve is Dennis.
Thank you, Dennis. Could I have a second?
Second, 7.
Thanks, Mark. Okay, so this morning, we have our traditional issues we go through on each of these meetings. What I wanted to do, though, most importantly, is discuss some current events, i.e. COVID planning, implementation, surge plans, and really the things that are affecting us right now. I wanted to open it up to everyone on the committee so that we can discuss ways that we could facilitate this process with a communication between pre-hospital and hospital and the Department of Health to really come up and be able to have a forum that we communicate what's happening throughout the region in terms of people's being overwhelmed with services requests, or from a perspective of the hospital having significant holds or delays in our departments. So the reason why this was brought forward was some communication that happened on the weekend. Mike, do you want to just give a little interlude?
Actually, sure, I will start, and I'm going to turn it over to Dave Violante. But on Saturday evening, there was some discussion, and some of us got some phone calls with regards to some surge that was occurring in the area and was affecting some of the turnaround times, as well as inability of some of the agencies to get out, and created a significant void, specifically in Dutchess County. And so we reached out to the Department of Health, then the counties, both in Dutchess and Ulster, and touched base and really just did an overall system status check at that point. But it certainly brought to light some concerns as to where we all stand in this process, as well as some of that communications. And I'll just quickly defer to Dave to see if you want to add anything else besides that, Dave.
Thanks, Mike. No, I think you really covered it well. We're sort of at this floating point in the water where there's times we're above and times where we're just under. And we had 50 to 60% surge in our system over an afternoon to evening, with an increase in those numbers being COVID patients, and sort of coupled with some of our declining volunteerism. We have reduced number of ambulances, increase in decon time because of the increased number of COVID patients, some decreasing in staffing and staffing issues amongst ourselves as well. And so that created a little bit of a perfect storm, where we were just not able to get coverage in the county like we normally would want. And that really delayed some things for us. And we fully know that that's happening in other places as well, around the state and other parts of the country. And so we wanted to get together with this group. It was really apropos that there's a REMAC meeting this morning to try and figure out how we can work together to, at the end of the day, make sure that when someone calls 911, they have an ambulance coming to get them to the hospital if they need to go. And if they don't need to go, that's fine too, but we need to get them medical care and figure that out. And so that's kind of where we are. I think COVID has been the great magnifier. Things that are going well really go well, and things that don't go well really don't go well. And this may be one of the things that we have an opportunity to work on.
And I think one of the things that Mike and I touched on, he called me right after you guys spoke, is the communication and how can we maybe improve our ability to communicate these issues. Certainly during that same time frame, our ED had 80 patients sign in an hour. That's a pretty remarkable number to handle in 1 hour. I wouldn't be able to tell you how many were COVID and how many weren't, but we're seeing the surge from Christmas holiday, and it's 10 days now, so it's really the surge from that community spread. Community spread is going pretty crazy right now. I don't know if you guys and other institutions, our biggest concern is employees that are getting exposed in the community, and that either come to work and don't realize it or come to work sick. So we've had a few exposures here that we've had to clamp down on because people are not understanding how, you know, asymptomatic carriers can spread this along so easily and cause more of a problem. Certainly the Christmas holiday we knew was going to provide a surge. Each of us from an institution, I'm sure you guys are aware, have to present and supply the state with a HERDS report every day. Your response, your capabilities, both from a perspective of just beds, surge protection, and your ICU and ventilator occupancy. So all that information is sent to the state every single day. We submit it in a report. So it's a process of Haney's actually put out some nice data. I don't know if you guys have seen some of these graphs that shows the percentage of positivity and the percentage of occupancy and surge for each institution, and actually shows it in a percentage form. So it does help us look at and see within our scope and our area. I did not know this was going on in Dutchess until these guys reached out to me. So, you know, just food for thought. Do you think there's, because we've had, you know, forums, we've had, you know, meetings and get together with the community providers from both volunteer organizations and paid organization, commercial organizations. And we've had a couple of great, you know, events to really talk about and hone down on issues that affect us all. So this would be one of those processes where we could really benefit from improved communication and ability to utilize what we have, and to be able to, you know, maybe flex during a surge time and be able to help each other out, and use our resources in an improved fashion. So I wanted to bring it to the forum today to see if anybody has any concerns, comments, issues, things that use that have worked, things that we think we can go forward with, and maybe open a forum of whether it be a task force or a community kind of process where we all work in a forum to try to work through this issue, because it's going to only get worse here now. I think we're going to go into the New Year's surge. And also, if you've seen in England with the new variant strain, it is so much more infectious and contagious that, especially in the age group 20 and under, that has caused their infectivity rate to skyrocket. I don't know if you've seen some of the graphs this morning. England's really in trouble. So I open that up to the forum of everybody, because this is the one way we can communicate and discuss things that are going on. But this is an issue I thought we should bring to the forefront sooner rather than later.
Hey, Pam, one of the things, this is David, everyone. We have a Hudson Valley Regional COVID Task Force that we've been meeting since March weekly. And then we stopped somewhere around May. We reinstituted it a few weeks ago. That may be a great place for folks to have a discussion. We have public health, EMS agency leadership, state leadership from every county on that call. And we do it Tuesdays at 3 o'clock. I can have Bill, or we can ask Bill if he would send out the information to everybody here if you want to join in on that. A number of those folks are on here today. We sent out an email to them so that they would be able to provide the REMAC with any information or data from their counties or thoughts that they had as part of that committee to make it easier for this discussion as well. So thank you all for who's on there, on that task force joining here today too.
I have a question for Rich Robinson. Good morning, Rich. Thanks for joining. So Dr. Murphy mentioned earlier the information that's submitted to the state dashboard on a daily basis. Where does that information go? And is there any opportunity for county leadership or those in these decision-making roles to see that information. I think one of the challenges that we faced on Saturday night was getting a real good understanding of what the situation was in our area, and live data would have been helpful.
So based on that HERDS data, it's reportable every day, as Pam alluded to, between the hours of 9 and 1 p.m. When Dave called me on Saturday evening, obviously I was not aware either. I had immediately called Deputy Director DeZora of the Bureau. So the Bureau of EMS is heavily involved in the surge and flex components of what the governor and Dr. Zucker have requested facilities to do. Based upon that, Steve was able, first off, the HERDS data is proprietary to the Department of Health. If a facility chooses to want to share data, that's up to them. But what I've been told, and I had begged the question yesterday, knowing that we were going to have this discussion today, that a facility is likely to not want to share that information. So, and it's not even shared facility to facility. So for obvious reasons, right? So going forward, we've had this surge and flex operational. It's been heavily utilized in the central New York area. The design of this thing is that we kind of funnel it into one operational center. So not only is Steve involved with that, the deputy commissioners, Dr. Heslin, Dr. Becker, are both involved, and as well as others, obviously. So based upon the information that David had presented to me on Saturday evening, I had called Steve, and he got the ball rolling. So what does that mean? And obviously the information that he gets is only as good as the expeditiousness of a facility getting back to him. So he did contact both facilities in Dutchess there, both Mid-Hudson and Vassar. And, it takes a little bit of time. It's unfortunate, it's kind of like the perfect storm also. So as things begin to get rolling, it seems to be that some of that stuff occurred at shift change. So, getting somebody that, is, first off, it's the scariness that why is the health department calling us? Why is the health department wanting to speak to the administrator on duty and all of that stuff? So the, for us though, it is helpful. And we do have, obviously, you guys know what my staff consists of, but we are not unwilling to send someone out and go and check on an emergency room to see where they stand. This is not anything punitive. We want to be able to facilitate, the movement of and see where we're at. Now, certainly, I think some of which, as you, Mike, and David have alluded to, this was a little bit of an anomaly, right? So you get a bunch of calls dropping all at once. I don't think there's any system that, around us that are going to be able to handle that. And certainly the problems that we're seeing is, being able to activate that mutual aid. But, what the state is currently working on also is entering into agreements with varied providers, not necessarily all commercial, whatever, to stand up agencies in the event that the need arises again. Because honestly, we certainly realize that activating the NAC again and getting 350 ambulances in here again is probably not going to happen considering what we're seeing going on across the country. So having spoke to some of my colleagues that work for AMR, there were periods that they were deployed for weeks on end across the country. So I think, we're kind of going to be left up to our own means. And, there's various components at the state level working on securing, contracts, our administrators working with budget and trying to get this to happen so that, we can function. And obviously we know that we need to be able to function. So the HERDS data, like I say, it is proprietary. So I learned that. So I have no trouble in sharing that with you. And I think that, I don't mind getting the calls. And I think unless you call and let me know, I don't know. I mean, unfortunately, I can't monitor, all the counties that encompass Marrow. So the information that we get is only as good as what you give us. And we're more than happy to try and lend the assistance. I mean, because, we don't want to be behind the 8 ball. I mean, and obviously we're building, it's an upstream battle for a little bit. But, and I did even speak to, one of the providers in the area just to kind of get a sense of, what's staffing looking like. Do you have a lot of call outs, and has there been people, that, you're having a tough time? And I think that's some of the dynamic that we're dealing with also. I mean, so that's where we're at. Hopefully that answered, give you a broad 10,000 foot view of what's going on. But again, please, you can reach out to myself, reach out to any one of us in the Marrow office. So, I mean, available to you is myself, Guy Carpico, Kevin, unless he's on the sat phone in Mexico. But Mike Lenahan, and we do have, there's enough people, especially that are available to you, but probably the first phone call, have it come to me, because my guess would be that not everybody is as diligent as keeping a ringer on in the middle of the night. So it's not a problem. We're all working on varied other projects with vaccine monitoring and such, pretty much 7 days a week. So please reach out to us. That's the only way we're going to know. And we certainly do want to help. And, Steve was actually, we had gotten on a phone call with David and John and myself and Steve, and, walk through some of these processes. So I think it's helpful, and we welcome it.
Rich, thanks a lot. I think you bring up a really good point that the hospitals are in a better position to understand and look at their data and information and report it to the state. And that's only one facet that happens in a surge issue. And it sounds like in this case, especially, the hospitals were much better off. The other side is the EMS side, and how can we report that, and how can we get that information, and how can we be able to say, when who's available and not, to be able to meet the needs of the community also.
Hey, Rich,
Go ahead, Bill. I'm
it's
sorry.
Bill. I'm sorry. Is there any guidelines as to, when you would want to be notified, or what would be a good time frame, or, something to guide people rather than having everybody call you all night long, and, for the same situation or for similar situations?
Well, I think honestly, I know there's nothing in black and white that says, here's the jump off point, you better make the phone call. So, knowing sooner than better. I mean, even here it was, when David had called me, it was like, hey, do you know what's going on? I was like, no. I said, but I'm listening. So, but I think that's helpful. I mean, and typically, if somebody, here at least, it was one cohesive voice coming out of the county. So maybe that's a good way of doing it, whether, that it funneled through either if there's an EMS coordinator for that particular county, and or somebody that's experiencing, leadership of one of the agencies, like, hey, we're getting killed and we can't keep up and we have a problem. And, anecdotally, some of the problem is being said that it's at the hospitals. But, again, when we looked at that, when Steve looked at that data and did communicate both with Vassar and Mid Hudson, that was not the case. The case was that, their HERDS data was spot on. I mean, yeah, there was a little bit of an increase, in both emergency rooms, but as pretty much was told to Steve, was that, nothing that couldn't get handled. And I know Dr. Papish had just left his facility not that long ago earlier. And, so it was kind of like, boots on the ground right there. So we kind of had a good sense of what was happening. So a lot of words there, but yeah, Bill, I don't think there's any perfect solution. But again, my guess would be that we're all smart enough to know that we're not going to hit the panic button unless we've got some problems and we see that the problems are not resolving relatively quickly, So I think that that's helpful. And that really even goes, and I'm sure, the docs on the line are well in tune with the whole HERD survey piece and the direction in which that's going. But, we've been dealing with this stuff now for probably the last 2 weeks. And this is the first one that I'm aware of that's hit down in the Hudson Valley, region, including, Westchester. And, my guess is it's probably not going to be the last, as Pam alluded to. I think we're only seeing the tip of the iceberg right now. So it's, unfortunate.
The other thing, Rich, you brought up a good point, and I forgot to mention is that some institutions are definitely having issues with staffing because of the community spread. People are just not being diligent of
Right.
not having kind of groups together. Even if it's your family, they still can bring, the exposure in there. So it's really a real issue. I forgot about that. That has definitely impacted employees.
And the other thing, and I had found this out yesterday, I was talking to an agency, and it's food for thought for everybody across the whole call here. This particular agency has a large number of employees, and they've had over 60% of the employees refuse the vaccine, which is mind-boggling to me. And so it really, I obviously I know it's not a mandatory thing, but and I was asked, do you know if anybody else is experiencing that? So, I don't know. I mean, honestly, from what I gather, I've been doing monitoring of the vaccine at facilities, at hospitals, and that could go either for employees and or outsiders, and have not seen that. The numbers have been very low on people not wanting it. But, this particular EMS provider was at a crossroads, and, they were kind of every morning they're trying to beg people to go get it. And, obviously we can't force it into people's arms, but just food for thought on that one.
So, I think that we have a great forum for the discussions with regards to the hospital and the pre-hospital setting through the task force that was set up. Again, in the spring, we were very active, and we've recently reactivated that. I think that it's important, and this is really directing this to the physicians on the group. I think it's really important that we ask for the support of the hospitals in understanding what the current status is really on a weekly basis. So this came out of no place. On Saturday night, all of a sudden the phone started ringing and everybody saying, what's going on and where is it going on? And unfortunately, we didn't have information readily available. I mean, obviously we're called Rich, and Rich called Steve, and thankfully all of those folks got involved. But we really didn't know where we were at in general or where we're at right now. I mean, right, every hospital that's represented here right now knows what their current capacity is. But we as EMS providers and the EMS community really don't have an understanding of where the hospitals are and where they stand. And so that's one of the things that we did do with the group in the spring is that the information was reported from the hospitals into the EMS coordinators, and they would provide us with reports. And again, it's a barometer. It's just an indication of where we stand. But you know, I think that's really important that we know that. And we also were reporting the same thing from the EMS agencies. So what kind of staff did they have out? What were they seeing with call volume? What was their ability to be able to handle the load? Would they be able to do any surge capacity? And at the same time, as part of that process, we were looking at volunteer EMS staffing. So we had asked for volunteer agencies to, and commercial agencies, but to let us know if they would be able to help out in the event of a surge situation. So certainly, you know, I think that, and I appreciate, you know, Dr. Murphy bringing this to this group, because we do have all of the physicians on here. And, you know, as Dave alluded to, we have a meeting tomorrow, but it would be very helpful if we knew what the status of the hospitals were and the EMS agencies, so that we can be better prepared to respond to these situations. You know, I agree that I think we're going to get back into this. I think, in fact, I think we're going to see it worse than we saw it in the spring, and we don't have the ability to push people out like we did last time. And so I'd like to hear from some of the docs with regards to, you know, sharing of that information and what your thought process is on that.
Okay, so I've got a couple of comments here. One, certainly in terms of, as Richie Robinson said, this is Eric Larson for folks who don't have visual. So a couple things. So as Richie said, in terms of the FEMA national contract, national ambulance contract, that has been stretched, and I don't think we're going to be getting a lot of resource from that. You know, at one point in the spring, certainly there were several hundred ambulances from around the country with crews in the New York City area aiding, and the lower Hudson Valley aiding with transport of patients, and we may not have that. But having worked on you know, some of this with the Greater New York Hospital Association and also Haney's, my understanding is that there's supposed to be an HCCC, a hospital coordination communication center, okay, for each of the 10 regional areas of New York, the Hudson Valley being one of those regions. My understanding is that HCCC is supposed to be at Westchester Medical Center. And this would be, you know, look, the hospitals are driving one part of this, which is what is their patient load, what is their ability to handle, and the idea is, you know, to load balance, and the HCCC is supposed to help with that load balancing and supposed to be the central communication point for that overload if hospitals are starting to get overloaded. Now, I don't know what the status of that HCC is for our region, but we need to get that clarified. In addition, you know, we need to, in addition, what we need to do is then figure out how to plug the EMS piece into that so that they can help with the distribution or redistribution of patients. And so those two pieces need to be put together. I don't know what has happened with that, but that was my understanding of where that sort of document was going with the state. And we were supposed to have, like I said, a central communication thing. One of the things I know for this region is that certainly, and this again, we talked earlier, well, in the helicopter meeting, but we've talked earlier on this thing, that the MACE was going to be a part of this because they are already an entity for emergency preparedness for every hospital in the Hudson Valley. So there are, you know, those pieces need to be linked up, and I'm not sure what the status of those are as of right now.
Okay, Dr. Murphy, this is Rich Parrish. Yeah. I generate a report for Ulster County and I share that with the EMS coordinator, and I believe he shares that with the task force. I don't know what Dutchess County does, but I have to have that report into the county exec every morning, 7 days a week. And as far as the MACE team, yeah, I've been sitting on these meetings. I do share with them. Yeah, and I believe that, yeah, they need to get more involved in this, and I'll get with the team. But I sit on the task force and, again, share that information with them.
All right, thank you. Thank you, everybody. I think that, you know, we just need to make sure we keep the communication lines open and, you know, as, you know, we get more, you know, forward into this, as Dr. Larson is saying, there is supposed to be a venue, and hopefully that will move forward. I think now more than any time we could use it, and it would be a great tool for all of us to communicate through. But I think that what we should do is make sure we're aware of these issues, and if people see that you know, we're on the precipice of something going to happen that such that, you know, a system falls apart, then we need to just communicate so we can all help out together, and, you know, again, get through this, because I think we still have a long ways to go. Just one comment about vaccinations. So, you know, Rich, it's an interesting phenomenon. In RED, 100 providers, 98 accepted the vaccine. One gal was pregnant and one gal for religious reasons did not, but 98 out of 100 accepted the vaccine. But our nurses in the same ED, only 60% took it. 40% are stating to the effect of they're afraid it's going to interfere with their ability to reproduce in the future, and that if they want to get pregnant, they don't want to have the vaccine, et cetera, et cetera, et cetera. So, you know, I just keep providing them documentation and literature and reasonable things for them to read, because most of them are watching and listening to things that come up on Facebook and other social media sites rather than really looking at the science of it. I try to keep pushing that towards people. We're almost up to 2,000 people we've vaccinated at the hospital as of today. So we've been pretty aggressive, but all I can say is people need to get vaccinated. We should all be becoming vaccinated. And I think if anybody watches someone die from COVID, how they smothered to death, would think they'd want to be vaccinated. But I don't have an answer to that. But it is very ubiquitous that a younger generation does not want to be vaccinated.
I believe that's what they're seeing, and no different than what you folks are doing. They have a sign-up table set up at shift change, you know, just handing out that information and, you know, kind of debunking the, if it's on Facebook, it's got to be real, right? So.
Pam, you're on mute.
Sorry, I try to go on mute because I hate background noise, even though I'm in here alone, probably not making any, but sorry about that. So any other comments, or we'll move along in the agenda? I appreciate everybody's time this morning. I think, you know, keeping these communication lines open, you know, the resurgence of the Hudson Valley Task Force is important. And I think we just need to, you know, make sure we communicate all these issues and try to work these things out together.
I have not reviewed the participants, but is anyone from the Westchester Medical Center on? And do they have any idea of what they're ramping up or what their role is in this? Because my understanding is they've been designated as the area center for this region for coordination.
I know Tina couldn't come on the call. She was working the overnight. So I'll ask her after.
Yeah, because that would be important information, especially Eric, if it's a process of that we have to centrally localize through that venue to provide the information and really keep tabs on what kind of surge and flex positions we have throughout the region.
Hey, Pam, one of the things we had done previously, and maybe this is worthy of a little bit more discussion at this point to see what the physicians on the group feel about it, is if this is helpful for any kind of surge, is the stay-at-home protocol, as it were, where if a person really didn't need to be in the hospital necessarily, in concert with medical control, in every case, the person could be left at home. Is there any thought about that would potentially help some surge as it came in for the hospital and potentially for services and turnaround times? I don't know if there's been some pros and cons since we instituted that at the beginning of the year, and maybe that's worthy of a little bit of a discussion with this.
Well, I think am I muted? Okay. I think the one thing that was unfortunate with what happened, earlier in the year was the outline or the points they wanted you to follow, and the process was a little bit late in delivery. So it was coming out after, we really did have the big surge of COVID patients. So it actually wasn't helpful. However, I think, any provider that comes across a COVID patient can call medical control and they can discuss the issue. We pretty much, we discharge a lot of COVID patients, from the emergency department and from in-house. So the only problem is when they have to be discharged to a congregate living facility. As you know, they cannot go until they have a negative test. So I have about 36 beds right now being occupied by people waiting for a negative COVID test who have no symptoms, are on no treatment, need no acute care. And we've reached out to the governor to try to change his edict about that. And it's falling on deaf ears. It sounds like he's not going to change it. But I think if you come across a patient in the field and there's a question, because some people freak out as soon as they find out they're COVID positive, they, oh, I got to be in the hospital. And we all know that's not true. So I think having a conversation with medical control, one of the things we use as a criteria here is, besides how they look, besides how they sound, besides their vital signs, is a quick stress test with a pulse oximetry on. That's how we decide to send people away from the emergency department. Literally no desaturation and the person pretty comfortable and not having any abnormal findings. We tell them, to stay at home, to go home, and tell them, the indications to seek care again if anything occurs. The bewitching days I've found is around day 10. That's when people can either get better or they get worse. So I don't know, this is just from the data we're looking at here at this institution, but it's a process people can use. But again, I think a conversation with medical control would never hurt, because maybe some of these people do not need to be transported and you could save valuable time. And
yeah, I think it definitely needs to be done in concert with medical control, though, because unfortunately we saw some people that were, left at home that probably shouldn't have been in the spring, and then ended up coming into the ER when they're already crashing with SATs in the 60s, low 70s. And, it's evolved a little bit. We don't have great treatments, but we do have some stuff we can offer them in the ER. And a lot of places are looking at programs where we can send people home with a pulse ox, with some more advanced monitoring than they might not. But it's the best bet is always to go through medical control and have a discussion, to see if it's something that would be better served outside the ER or not.
Yeah, they have to go through medical control, Jeff. They can't make that decision.
Yeah, agreed.
Yeah, there's no question. And again, like you said, some of the advisories we were given were a little bit late in the game. So I think, we just have to review all these processes.
Yeah.
One thing that's also changed since the spring is, we can debate or not debate the evidence for monoclonal antibody treatments. We do have some treatment that can be given in the emergency departments for patients with mild to moderate symptoms who are going home. And so if they don't come in, we can't provide them with that care. And that decision is based on not just their symptoms, but also on their age and their comorbidity. So it's a much more complicated decision than just, do you look okay or don't you look okay? And are you hypoxic or not? Actually, these patients, if they're hypoxic, aren't this medication is not available to them, but there may be other medications that would be provided in-house. So I think it's a much more complicated decision now than it was 9 months ago. And certainly can be done through medical control, but I think we just have to acknowledge that there's greater complexity to that right now.
Yeah, the only place we're able to provide monoclonal antibody therapy is in our ED. We've not been able to move it to anywhere else yet. So absolutely, Gigi, anybody with low to moderate disease, just so you guys are aware, so their pulse ox is above 94%, they look good, but they have extensive comorbidities, as Dr. Midori's talking about, that they have a risk for really getting sick later. Those are the people we want to try to give the IV monoclonal antibody. It's a 1 hour infusion, and then you have to monitor them for 2 hours after. But it really is something that we can offer to patients that are willing.
And even those that are just older patients over 65 with no comorbidities. So it becomes, and then there are a different group, different list of comorbidities for those under 12 to 17. And it just, it becomes a much more complicated decision that I wouldn't want to put on the EMS providers. I think it has to be done either by bringing them in or by discussing it at least with the providers in the ED to make sure they have medication and that they fit the criteria.
So I appreciate the comments with regards to that. And I think it's important that we remember all of that. I think the challenge that we have, and maybe it's time that we reissue that, the challenge I think that we have is that the state still has the pandemic treatment protocol in place without medical control. Thankfully, this region issued the advisory, which says that medical control is required. So it might be appropriate for us to reissue the Hudson Valley advisory, just reminding folks of that, and also discussing this treatment option so that the EMS providers are aware of that. So the folks on the street need to know the information that Dr. Midori and Dr. Murphy just discussed. So it might be appropriate for us, Bill, to recraft that advisory slightly and reissue it.
We're now starting to get calls on a daily basis for patients who are keeping up with the treatments and looking at the CDC website, and they know that monoclonal antibody treatment is available at some places, so they're calling us and asking about it. So I think many people are kind of staying ahead of the literature and staying ahead of the treatments, and so I think that EMS has to be, and all of the EDs have to be aware of that as well, because you're going to be asked that as well in the coming weeks.
One of the barriers with the monoclonal antibody therapy, though, is you need a positive test already. So when patients come into the emergency department, unless the ED has a rapid test, oftentimes it's a 2-visit issue because you have to get tested, then you have to wait and see what your results are, then be eligible. So for the places that have a rapid test, that's great, but most or a lot of EDs don't. It's another barrier. That's what I agree, Gigi. It's really complex.
Yeah, and so it's actually quite helpful for EMS to be aware that we will require evidence of a positive test, a PCR test. So if someone is symptomatic and they're coming to the ED and they may be a candidate for monoclonal antibody, have them make a photo of their test result or bring their test result with them so that we can see that, and it saves on some legwork of our calling a clinic or calling the Department of Health or calling CVS and trying to get that result. It's much more helpful for them to have it in hand.
This makes the SLAMS criteria super easy in comparison.
Okay, thank you, everybody. Any other comments, or I'll move along in the agenda?
I'm just in closing that conversation. Tomorrow we do have a task force meeting. I think it would be extremely beneficial if all of the folks on this call also had an opportunity to call in. Let's move it from the REMAC to the task force so that we can actually get some of this stuff done, figure out how we can move this forward. Maybe it's MACE, maybe it's bringing in this hospital communications group. But somehow I think we need to get ahead of the wave and be ready so that we're not in a situation where it's too late and we're discussing this. So maybe we can get the region to send out that Zoom link to everybody here. And certainly we would encourage you all to participate tomorrow. And I appreciate the conversation today. I think it was very helpful.
Yeah, so Bill, go ahead and send that out to everybody so we can broaden the depth of our attendance and just bring in alternative areas for us to discuss and to really open that communication vehicle so that everyone can, really be on the same page, hopefully, and we can share information, share things that have worked, things that have not, and how we can move forward. So again, we're ahead of the curve rather than trying to chase up behind it.
Yeah, we'll send it out as soon as this meeting's completed.
All right, thank you. Next on the agenda is the iGel pilot project. I have to tell you, sorry, but it's still in CMAC and in, this kind of, I don't know what zone you'd call it, but I will still follow through on it. I reached out to Dr. Marshall because we have the CMAC meeting coming up. So I'll keep everybody posted, but I have nothing to add today on that pilot project, unfortunately. Service upgrades. Bill, do you have any service upgrades? You're muted.
The only thing I have is adjunct, BLS adjuncts. Does that come under service upgrades or is that separate?
It's really a notification that's read into the minutes, not so much under service upgrades, but you can read the adjuncts in now and then you can follow that with the enforcements.
Okay, we have Altwood Fire Department as a pad. We have Millbrook Fire and Rescue for glucometry, Armenia Rescue Squad Narcan, Ambulance New York 2 for albuterol glucometry and Narcan on their BLS units, Walden Fire Department for Narcan, Carhanson Accord First Aid Squad for CPAP, and Ambulance 2 is listed again. So it's the same one. So those are the agencies that need approval to use the adjuncts.
It actually is something we just push through to the state because as long as they file the proper paperwork, it's really not something we have to vote on, more so notification so that people are aware, but it gets processed through the state.
Actually, I thought the REMAC had to vote on them in general just for approval to say that they can use them. I mean, that's the way we normally do it. We do that, I think. They're approved because it says the paperwork that's here that's to go up there says the BLS adjuncts were approved at the Hudson Valley REMAC meeting on January 4th.
All right, so I will ask for, you can do a roll call vote for the people that are here. And this would be a motion to approve the BLS adjuncts that Bill just named off. If you guys need it to be named off again, we can. But if you can do a roll call, that would be great.
Okay, Pam Murphy.
Accept.
Mark Papish.
You got a thumbs up.
Okay. Dr. Rashad.
Accept.
Okay. Dr. Stu Miller.
Yes.
Okay. Dr. Mao.
Yes.
Dr. Midori.
Yes.
Dr. Raybridge.
Yes.
Okay. Dr. Greenhut.
Yes.
Dr. DeThomas.
Yes.
Dr. Cohen.
Yep.
And Dr. Larson. Oh. Okay. So we're good. It's unanimous.
Hi, Dr. Brutus is here too. I accept. Dr. Brutus is here.
Oh, okay. Thank you. Gotcha. Okay. So that's good. We got that. Now we'll go to the,
Enforcement.
right, the enforcements. So we have Hartfield Volunteer Fire Company for violation of Public Health Law 3030 and 3006 and Part 815 was suspended for 1 year effective 12/8/21. The suspension has been stayed pending no new violations for 2 years, and they were assessed a civil penalty of $2,000. We have Carl Delgado for violations of Part 815, Part 803, and Part 803 AP. Was assessed a civil penalty of $2,000 and is suspended for 3 years. He's out of the Bronx, New York. Brian McIntyre out of Long Beach, New York, for violations of Part 816, surrendered his certificate on 11/3/20. Then we have Nicole Mills for violation of Part 816, 1, 2, and 9, was assessed a civil penalty of $2,000. Half is stayed pending no further violations. And she was suspended for 1 year effective 10/26/20, where the suspension was stayed and placed on 3 years probation effective 10/26/20. And she's out of Newfane, New York. And that's all I have on enforcements.
Okay, great. Thank you. Next on the agenda is the evaluation subcommittee. Dr. Ashad.
So there are a couple of back burner issues, but I don't have anything to report today, just given our preponderance with things that are related to COVID-19. So nothing to report as of today.
Okay, thank you. Helicopter committee report, Dr. Larson and Dr. Stu Miller.
Good morning. So the helicopter committee met this morning. 12 of us were on the call, and we approved the revision of the Air Medical Services guidelines, and wanted to, of course, send that to everyone again, but also wanted to display it. They had just put in the chat for everybody to download and look on their own system. But if you don't mind, I'd like to just open it up really quickly. And
so Bill, you can share your screen with Dr. Stu Miller?
Allow me to share mine?
Yeah, you can share yours. I was just, because he started the meeting, I was just, go ahead, David.
All right. So I'll just go through page by page so you can see it, and I'll hit the highlights. You know, we'd appreciate it if the REMAC would approve it, as our committee has. So page 1, then there's table of contents on a couple pages. Just a welcome statement that introduces what this guideline is for. It goes to all emergency services agencies, law enforcement, fire departments, emergency communication centers, EMS. And there's a first responder reference, which begins with the operational criteria for requesting air medical services and canceling air medical services. The change on this is that this statement I'm highlighting in the middle, which I'll make bigger so you can see it. Only the primary EMS transport care provider may cancel a responding helicopter. This means that someone medical who evaluates the patient has to say, no, we don't need a helicopter. We felt that this was important rather than having somebody come and say the helicopter's not needed, and then the helicopter turns around, and then paramedic likely gets on scene and says, where's the helicopter? Oh, they were canceled? No, we need them. And so this is meant to say that unless you're canceling all advanced life support units, because there's either no patient or the patient is fine, if you only the EMS transport care provider can cancel the helicopter. That's the one addition here. We just clarified the auto standby procedure, the bottom, which is the same criteria that we've had in the past: explosions, entrapment, severe burn, the high risk crashes or pedestrian struck, penetrating trauma, mainly trauma, and additional criteria deemed appropriate by the Emergency Communications Center. So each Emergency Communications Center may have another put the helicopter on standby procedure. And then this is just the procedure on how the communication happens. There's really no change in that. Landing zone setup is no different. It's 100 by 100. Here's the landing trajectory image that was in the last version. How to set up a landing zone hasn't changed. Facility intercept, we just clarified that the use of a helipad to rendezvous with Air Medical Services is not an EMTALA violation on behalf of the hospital. That's been in there. It's been that way for years, but we just called it out very clearly. More specifics: landing zone operations on hazards and who can be within the landing zone, how they help, who directs them on how they can help safely, loading and unloading, patients and passengers, image of a rear loading clamshell aircraft and a side door sled loading aircraft, difference between hot loading and cold loading, images of the aircraft that you will see in R2 regions with some simple specifics on the side, including New Jersey State Police aircraft there that might be in the region. Agencies, addresses, type of aircraft. Here's where we need the help of everyone on the REMAC. I know we've asked you for these data in the past. However, during the first go around, some great suggestions were added. We broke out trauma into adult and pediatric trauma. And now that we are American College of Surgeons verified, we wanted to put the level of trauma center that you have been verified at as well for adult and peds. We also added VAD because that's was suggested, and we also added reimplantation as another specialized service so that we could call out which facilities have these capabilities. And so I just ask everyone to confirm one last time, if you haven't already in the last month, these criteria. So you can see up top here, these are the different hospital capabilities. We felt it important to communicate to everyone as sometimes these patients end up in helicopters.
Dave, is there a second page to that? I don't see Health Alliance on the Ulster County list.
Yes, page 2. Including out of region centers that are often touched by our Air Medical Services: Albany, Jacoby, receiving centers, and then Sharon and Danbury typically sending. So if everyone on the call today would please look at these 2 pages specifically and make certain that they're accepted, that they're accurate rather. And then we have a little guide: P for primary, C for comprehensive, T for thrombectomy, a guide for stroke centers, and then trauma, level 1, 2, 3, 4. And I guess we could have put NICU 1, 2, 3, 4 here as well, but you understand the concept. Then it ends with guidelines for the AMS providers and some of the language that is used. ETA specifies the auto standby procedure that the helicopter has. So if as it says here, if the scene is greater than 25 nautical miles away from the closest and assigned aircraft, the helicopter will automatically launch and do a standby, and then we'll wait to hear, confirm, respond, or you're canceled. And then we ask that you say why the helicopter is canceled so that we understand our utilization in the region. And then specifics for our crews on how we should keep the other emergency response personnel safe. Our own hot loading requirements, our own hot offloading requirements, And that's the document. It's actually shorter. It's only 17 PDF pages. So we've, I believe, made some changes that make it more clear, yet communicate everything that's important. And so I respectfully request that the REMAC approve this.
So I think it looks good, David and Eric. Thanks for working on the document. Does everyone on the committee who would be voting feel like you have enough time to review this? Do you want to look at it more? I mean, think the one thing people need to get back to you, David, is if they have changes in their, capabilities for your, your chart. That would be the only thing that people might need to get back to you on. Otherwise, I like the way it's set up. I like the way you have it, defined. And you're right, it is a shorter, more to the point document. I think you guys did a good job. So if everyone's comfortable, I'll make a motion to approve the document, albeit there might be some alterations in the receiving hospital capabilities in the chart. Just if people have not, if they need to add things. Putnam said that they do have an LZ, so that was one thing you can add on there. If everyone's comfortable, then we could make a motion to approve this document.
Hey, Pam, real quick, I have a question. I think it's fantastic and I think it should be approved. I think it's amazing and great work and it's very helpful. The one question I have is Vassar's helipad is now on the roof of the hospital. What does that do to anything in terms of patient movement through? Would that be an EMTALA issue, or would that then just patient goes to the ER and away from there using the hospital ER?
So David, I don't know if you want to answer that, but it's still not an EMTALA violation.
Yeah, it's actually, this was asked and answered by the, whatever, I forget which federal agency has jurisdiction, but you can land on the roof of a hospital and walk through the hospital outside and put the patient in an ambulance. And that hospital does not incur an EMTALA violation. Because this, and some hospitals say, absolutely not, we're not going to test that guidance, we're going to see that patient. So the facility may have a different take on it, but from the federal EMTALA regulations people, you can walk through a hospital and they don't have an EMTALA obligation, unless the patient or the EMS personnel moving the patient request evaluation. That's the patient can say, I want to be seen, and then EMTALA.
Yeah.
Thank you so very much. I know we'll be asked that question for sure.
Dr. Murphy, this is Dave Jensen. That has been confirmed by Vassar's legal team that it's not an EMTALA violation.
Excellent. Yeah, it really isn't. Just like Dr. Stuhmiller is saying, this has been weighed in on it, and there's actually case law about it, that it's not an EMTALA violation, just so people are aware. So without further ado, I'll put a motion on the table to accept the helicopter committee report and documentation of, what do you call it, David? Is it your operating medical service guidelines? There we go. Air medical service guidelines, not altered mental status, but air medical service guidelines. Could I have a motion to approve? We have to do roll call again. Bill, can you do roll call? Please?
Well, I will move to approve the guidelines then.
And this is Dr. Arshad. I'm happy to second that motion.
Okay. And Bill, can you do a quick roll call? Are you on mute again, Bill?
Probably. I don't want you to disturb anybody. Dr. Murphy.
Yes.
Dr. Papish.
Approve.
Dr. Ashard.
Yes, sir.
Dr. Brutus.
Approved.
Okay. Dr. Mao.
Approved.
Dr. Midori.
Approved.
Dr. Raybridge.
Approve.
Dr. Greenhut. Dr. DeThomas,
Approved.
Dr. Cohen.
Approved.
Okay, that should do it. That's everybody. Unanimously approved.
Thank you all.
Okay, moving down the agenda. We have RTAC. Eric, was there any meetings of RTAC since the last REMAC meeting?
There has been no meetings and we do not have a tentative date as of yet. I think they are thinking about it, but I haven't heard anything as of yet.
Okay.
I know Dr. Quintero, who may or may not be on this call, was in contact with them, and we're pending notification of a possible date.
Okay, sounds good. Jeff, are you on the call for quality improvement report?
Yes, I am. Okay, what I've been working on for the past couple hours that I've been back in the office is migrating all of our dashboard data over to the Google Data Studio. It's a better, more powerful platform for us, and I can put it on the website with a couple of caveats. Not all of the data that will be displayed is going to be mineable. Most of it is going to be looking at individual counties rather than pulling it down to an agency level, simply because it's not really appropriate to share individual agency data publicly. If an agency wants data, they can make the request to us. We will pull the data and forward it to them. The other thing that I've started to work on is pulling out COVID data, and should be getting that out to the county coordinators in the next couple of days. And that's basically it for the new year so far.
All right, thank you, Jeff. Sorry, I just have to answer one quick thing. Next on the agenda is would be any kind of additional adjuncts to certain cores, and we went through that when Bill did the enforcement letters before. So that moves us along to protocol committee. Michael Beninati.
I'm now calling him Dr. Beninati.
I know, right? I just almost did.
We don't need to do that. Okay, so actually I have several things, but I'm gonna make them as brief as possible. This is the most important one that I think we need to discuss, and I unfortunately don't believe that we're ready to do this yet because we're just retooling the tool itself. But there was discussions, and there have been discussions here in the past with regards to stroke care. And there was a special stroke meeting held between the Hudson Valley and the Westchester regions. And it was essentially decided by the group that we would move forward in the use of the SLAMS system, which is the one that is used in New York City. And so, I'm quickly showing it to you here on my screen, just so that you are familiar with it. We just need to revise the document for use by the region and just, clean it up a little bit. There is also, so the New York City one's got lots of protocol stuff in it, which, we're not going to include. This actually is the SLAMS tools that we would actually use to determine the total score. Then certainly based off of the total score, so these are the, all of the education behind that. We decided that we were going to leave it out of the chart, however, provide it as a tool for training the EMS providers. And then I'm just going to scroll down. So then at the bottom of the screen certainly is the actual decision-making process, the discussion of the transport times, and where we go. Some of the exclusion criteria, cleaning that stuff up. But that was generally the consensus of where we would want to go. Actually, and what, I'll defer to Dr. Papish, just he spearheaded a lot of that conversation. Doc, did you want to add anything to that conversation?
Just that the only, the thing that we were debating removing with regards to the wheelchair and bedbound, is that, can we go back up to that?
Yeah, actually, maybe you can't see it just because of my other, let me see. Now, can you see that as the exclusion criteria on the right side of the screen or not?
Oh, there it is. Yeah, sorry. My own picture
Sorry, it was
was
behind my, my Zoom window, so.
So, yeah, I discussed this with Berkowitz about a week ago too, and he didn't have a great answer as to what, the debate was for patient, the exclusion criteria all seem pretty rational. The only one, the fact that somebody's wheelchair bound, excluding them from potentially an endovascular intervention that could differentiate them from becoming bed bound or functional and non-functional, seemed somewhat arbitrary. And should we decide as a region just to remove that section?
Yeah. So in the original development in New York City, that was put in actually at the request of the neurointerventionalist group from the different comprehensive centers in New York City. They felt that they wouldn't be as aggressive with those patients, but our region may feel differently.
Yeah, and so removing that, I mean, the other thing I feel like sort of like there's a potential for the ACLU to get involved, or just somebody that is wheelchair bound still, if they're acutely aphasic, and they could really benefit from that therapy. So taking that out, I mean, if anybody had any objections, I feel like it would be
I think it needs to come out.
Yeah, I agree. It is problematic.
So if we got rid of that, is there anything else that anybody would think would need modification?
Are you using thrombectomy stroke center and a comprehensive stroke center as being the same?
Yeah, thrombectomy capable, yes.
But that's not the same as a comprehensive stroke center.
Right.
So are you saying they're synonymous? Because they're not synonymous.
They're not synonymous, but for the purposes of acute stroke, what really the issue is, can they get an endovascular intervention? And so anybody that can do a thrombectomy would be a destination for these patients, ideally, even though those places wouldn't take care of aneurysms and other things that the rest
For
of
the purpose of the protocol, it's comprehensive stroke center plus thrombectomy capable.
Yeah, they're still not synonymous. I mean,
I know, but for this purpose, they are from a EMS delivery point of view.
There are other advantages for a comprehensive stroke center, and there are other implications for what that involves that you may not be included with just a thrombectomy stroke center. Like, why wouldn't you go through the ordeal of becoming a comprehensive stroke center if you could do embolectomies?
All right, say that again. The last part.
If you can, so why would you not be a comprehensive stroke center if you can do thrombectomies? There must be something holding, there may be some capacity that you don't include that may be important, but they're not synonymous.
Right. The other benefits of a comprehensive stroke center are they do aneurysm management, which most, an endovascular capable center wouldn't. And I think the other issue that somewhat precludes some places from becoming comprehensive stroke center is absolute numbers. There's a requirement to do a certain number of procedures per year to be a comprehensive stroke center. I don't remember what those numbers are, but I know that like other endovascular capable places in our region haven't become comprehensive because of that. But I don't know, maybe there's something else too that differentiates the two. But for the purposes of getting an endovascular retrieval, it would seem like they would be equivalent as far as they could take care of the acute issue. And then if the patient needed higher level of care, they could always manage it.
Plus the plan is to expand access, right? There's not many comprehensive stroke centers, right? Between Westchester and Albany, and then, so.
Yeah. So this would help raise the bar.
Just a quick question. Why greater than 5 hours last known well? At least where I live here in Jersey, they're doing basilar arteries 12 hours out. So what's
Yeah.
the,
That was a regional decision by New York City. We could certainly change that. They, in consultation with all the participating centers, they felt 5 was reasonable. It had been obviously 3.5, but so they increased to 5. But you're right. I mean, neurointerventional in some cases are happening up to 24 hours. So, 5 is kind of what they came up with for their region, was not based on any scientific information.
then I guess continuing that, we should ask Westchester and Albany how long they want patients.
And going back to the thrombectomy stroke center versus comprehensive stroke center, I mean, so we're potentially sending them to places that have the capacity to do an embolectomy, but just don't do very many. That to me seems problematic. And this is the way that it increases their numbers, I suppose, but it sounds like they should sort of prove their worth before increasing their numbers through
Right,
this
but
approach.
these are Joint Commission certified thrombectomy capable centers, so that's who they're proving their worth to. I mean, this is similar to like the PCI only, no cardiac backup, when we went through the whole STEMI evolution.
Does that
The other,
seem clear now?
sorry?
I was just asking if people felt that it's clearer now that they understand the purpose behind how it's listed.
But in regards to that number of 4, I think centers are commonly using 12 and even occasionally 24 hours in terms of their decisions to make thrombectomies.
Yeah, I think 12 is a more reasonable number. I think the city just, for logistical purposes within the city, didn't want to push it out to 12, and it was arbitrary and not scientific, but 12 is what a lot of places, even primary stroke centers, are using to activate a stroke alert, right, and transfer the patient. So
Why don't we, I agree with Dave. Why don't we reach out to the people doing the procedures in the region and see if they all say 6 and we're not doing them, or they all say 12, if they all give us different numbers, then we can come up with an average. I mean, obviously this is somewhat arbitrary, but it doesn't make any sense if no one's going to do the procedure after 12 hours to make it longer than 12 hours. And if realistically, they're saying they're not doing patients after 7, even though there's, like whatever we're actually doing is what we should tailor our guidelines to, right?
Yeah, I think if we reach out to the 2 centers, that would probably be the best way to answer the question and have a more, whatever they say is their number, just so we, utilize and be consistent.
Hey, Pam, just as a point of discussion, sort of based on our last discussion with Serge, our 2 centers are Westchester and Albany. Would that mean that someone that meets the criteria would be taken to Westchester or Albany either by ground or by air?
Yes.
And then, so just to insert here, where we are thrombectomy capable at Vassar, and we do quite a few interventions. And I was hearing the back and forth, there are a lot of assumptions being made. So exceptional coverage, our providers are on the ground, do this on a regular basis. One of the distinctions between thrombectomy capable and comprehensive is 24/7 neurosurgical ICU capabilities, which is what our primary limitation is. It's just not cost benefit wise relevant in relationship to the number of aneurysms that the hospital does on a regular basis. But in regards to thrombectomies, very good numbers, very good outcomes. And that's just a little bit of the distinction or flavor between comprehensive and the rationale for that.
So who's going to reach out to Albany and Westchester to report back?
Dr. Papish?
Yeah, I'll reach out. And Vassar.
Yeah, Dr. Arshad, so then you would be a thrombectomy center on the Air Medical Services guidelines then, right?
Correct, yeah, and our I think we're already marked in that regard. And then we do for 12 hours.
You do 12? Okay.
All right. Anything else, Mike?
Yes, I have some other brief reports that I'll make. I'm just pulling that up. So the other thing that we discussed at the protocol committee, and I'm not going to just, in the interest of time, we're 1 hour into this already. Shay Tetrall had done a nice EMS COVID-19 field guide that we spoke about at the protocol committee. Initially, it had some treatment information in it. That information's been removed and it's back before the protocol committee to look at. It's essentially background information on COVID-19, which might be beneficial to EMS providers. So we're going to relook at that and see if that's something that'd be worthwhile to distribute to the EMS providers in the region with regards to just background information. The next is the termination of resuscitation advisory was updated and redistributed. If you did not get that, please check with the regional office to get that again. There were some changes made to the patient actually being loaded in the ambulance. The region still needs to, and another word or two as well, I don't remember exactly what they were. The region still needs to update the corresponding chart and they were going to redistribute that as well. Also, a document was issued with regards to requirements for receiving medical control contact hours via Zoom or WebExes. So again, if you did not receive that document, please ask the regional office for that. And one last item is that there was a clarification document issued on December 2 with regarding medical control contact hours and how they play out for year 2020 and moving forward. And that's all I have. Thank you.
Thanks, Michael. So under new business, I had the COVID stuff on there regarding the vaccine administration that we kind of touched upon. The only thing I'll also add there is under New York State and Ryan Greenberg, the state put out a protocol of how EMS providers will be educated to be able to administer the vaccine in a proposal of setting up pods throughout the state to increase accessibility and acquisition of the vaccine going forward once the community is allowed to receive it. So as a group, I think 8 of us from the collaborative committee wrote back to Ryan with some suggestions for the program. The program was about 25 PowerPoint slides and is a 6 to 8 hour educational program. And so we wrote back trying to facilitate it to be a much more reasonable approach. We cut it down to 10 slides and would like to reduce the educational burden, to less than 2 hours. Just because we feel that pre-hospital providers give shots now and that to be able to facilitate them and move them into the arena of providing the COVID vaccine would be quite easy to do. If you remember, we did the check and inject program with epinephrine, with Narcan. And then we have given epinephrine to BLS providers with the EpiPen administration. So we put it forward to Ryan. We sent it yesterday morning. So we're going to hope that it'll be put on the CMAC agenda, which is the meeting up and coming. We want to kind of facilitate the ability of the pre-hospital providers to become qualified and recognized as the the forefront to be able to administer the vaccination process and really make it much more widespread once we're capable of doing such and allowed to do such by the state. I think that's it under new balance. There is no CMAC report because the meeting hasn't occurred yet. And anyone, for an open forum, anyone has anything they want to bring up this morning?
For people who may or may not be aware of it, if you're looking to get on another on another call, One of the things that the Bureau of EMS from New York State runs is they have regular WebEx meetings. The next one is scheduled for Wednesday, January 6th at 5:30. We can probably send that information out because a number of these topics will be covered by Ryan Greenberg and the other folks on the calls. So anyway, it's another point of information, and I've been watching that site and getting a fair amount of good information from it as the Bureau of EMS is formulating it.
Okay, perfect. Anyone else? Albeit that no other new business, I'll take a motion to adjourn the meeting, and I appreciate everybody's efforts. Again, we'll send out that information afterwards regarding the task force for the Hudson Valley region. And thank you everyone for attending this morning. Could I have a motion to adjourn?
Motion to adjourn.
Thank you, everyone. Have a great day and Happy New Year to all. Thank you for all you do.
Good year.
Happy New Year.